accepting our invitation. Dr. Shubhadra, Dr. Singhol, Dr. Ahmad, and Dr. Ahmad. Today, I am also between an eminent speakers. It's my pleasure and my honor to have all of them with us. Um, we will start. We will have actually two parts of our webinar today. The first webinar will be about ROP. Maybe in our area, we are the first people we are talking about ROP. And fortunately, we are having one, also two persons or speakers. They are well-known figures dealing with ROP. And I will start with introducing Dr. Shubhadra Jalali, a consultant ophthalmologist, director of Retina Institute, Newborn Eye Health Alliance, director of quality LG Prasad Eye Institute Network in India. Dr. Shubhadra, you can start. Thank you.
Assalamu alaikum to everybody. Namaskar from Hyderabad, India. Thank you for having me there. I'm really thankful to the Middle East Ophthalmology group to have me there. This is the first time I'm meeting all of you. So I want to just share with you about the ROP cases that have taught me a lesson, and few cases I will share just here with me. So I think the first thing I learned, because I got trained in USA with Dr. Michael Tracy in 1998. And when I came back and I tried to apply the American Academy guidelines to my patients, everything fell flat because all the guidelines were based on the postmenstrual age and the gestational age and the weeks. And my patients had no idea what was their last menstrual date, what was their expected date of delivery, when they were supposed to deliver. So then this is the slogan we gave, Peace in Roshni Ke, 30 days to life. So we said, irrespective of when you're born, what happens, there will be only one benchmark, and that is that by the 30th day of life, one screening should have been completed. And if it is a very delicate child, then we will screen within 20 days. And later on, the ETROP also said 4 weeks. So we were very close to what the ETROP was saying. And this 30 days to birth is what I'm known for in my country. Now everybody follows it. If the baby comes on 31st day, then a big letter goes to the neonatologist. Why did they send on 31st day? So everywhere this slogan is there, so we can benchmark, and that is, how we can make a difference. So I will start with some of the complications I had with laser, because we started with laser. That time there was nothing else. So this is a patient which, developed retinal vein occlusion during laser. And I'll go through this very unusual case. When this happened, I had already done more than, I think, 800 cases of laser. This was many years after I was doing lasers, and I had never seen something like this happening. So this was a 1-month-old female, really not very tiny. She was 35 weeks, birth weight 1600 grams. There was no major thing happening before. She was born to a diabetic mother. And she had a stomy course with incubator life for 21 days. She had seizures. She had had a blood transfusion. She had significant sepsis and received antibiotics for 15 days. And really the disease, I don't have the picture of the left eye which developed CRVO because it was unremarkable before laser, so I didn't take a picture. But it was exactly like the right eye. You can see there was just stage 3 early, small hemorrhage here, few dilatation of vessels. And really some people might even have thought that, no need to treat, I can also follow, because she was now 37, 38 weeks by the time she came to us. But since she had all these complications and she was from the old city from where our compliance rate is less, so we thought, okay, it's a early stage 3, we can go ahead and laser. And I asked my fellow to laser this patient because he had done 10-12 cases. So I thought this was a good case for him to do, because the pupil was dilating and the media was clear and it was a very simple case. So after he'd done the laser, he came to me and said, Madam, do I need to do the nasal side? Because there are a lot of hemorrhages on the nasal side. I said, but there were no hemorrhages in this eye. I don't think this baby had hemorrhages. He said, no, there are a lot of hemorrhages. You come and see. So when I saw this baby, I was aghast. The child has developed retinal vein occlusion. And I was so excited, because how many of the surgeons in their lifetime would see a retinal vein occlusion developing? And I was like, questioning him, where did the hemorrhages start first? Did the disc become pink first? Did the vitreous hemorrhage start? Did the arterial occlusion? He had no clue. He was just aghast. He said, oh, I don't know when this happened. So he had done decent. He had just put 2,000, 3,000 spots. It was not something very big. And so the first question in that crisis situation was, uh, where is Varshaw? Where is Varshaw's triad? Why did this happen? Did it happen because he put too much pressure on the eye due to indentation? But I thought that was unlikely because he'd really done a good job. He'd done good laser. If it was the pressure, then maybe he would have lasered only one area. But because he's lasered all around, so it was unlikely that there was a sustained pressure on the eye. The next thought was like, was it phenylephrine? Somebody has put many more doses and baby's blood pressure has gone up and CRV has occurred. But when we checked the baby's temperature, pulse rate, blood pressure, which are all side effects of excessive phenylephrine, they were all normal. We thought like, did the baby get dehydrated? We are lasering, the fellow is lasering, he takes time. But the baby was fed well and had no signs of dehydration. So we thought like, does it have a thrombotic tendency? Because we've never seen this happening. The more important question was now, what do we do to that eye? Should I give intravitreal Avastin? How can I follow this baby? There's no help from CVO study. CVO study says CRVO eyes, follow with visual acuity fields, RAPD, gonioscopy for NVI, NVA. Nothing was going to work in this. So how was I going to follow this CRVO? And more important was now, should I laser the other eye? What if the baby develops, CRVO in the other eye? But I was quite keen to laser on the same day because I thought now he's sort of one-eyed, and if I don't laser today, and then something happens to the other eye, goes into neovascular glaucoma, then the parents would not agree to laser. So I went ahead and lasered, and had a discussion with the family and sent the child for examination of the blood, but I did not inject on that day. This was a Saturday. The baby came on Monday, and you can see the eye had changed. So within 48 hours, you can see the CRVO was progressing. And that is what the literature tells us, that the CRVO is a progressive disease. The VEGF which is released into the vitreous cavity, it worsens the disease day by day. And you can see how the arterial narrowing has worsened. So yes, we got all the tests done and we injected on that day, that is 48 hours after the CRVO. And when the investigations came, it was that this patient had severe protein C deficiency. And going back to the literature, we found that systemic sepsis can lead to an acquired protein C deficiency. Patient was checked for mutation for protein C. It was normal. So fresh frozen plasma was transfused. And when we did literature search, we found cases of thrombosis of the renal vein and of the CNS happening in these babies because of protein C deficiency, but nobody has reported CRVO. I suspect that some of these patients may be going unnoticed because a CRVO in a baby would not lead to any symptoms when they had renal thrombosis or other thrombosis. So 2 weeks after that, you can see the right eye resolved very nicely. The left eye also, everything went away. It was dramatic. Everything went away. There's no CRVO. All the vessels have come back. We added some more laser and baby is doing fine. And this case was resolved. It was published. The next case I wanted to highlight, so you can see how it resolved within 2 weeks of the anti-VEGF. The next I wanted to highlight is a rare complication after laser. So we've been lasering a lot of patients. We had 3 patients, all had zone 1 disease, all were 27 weekers. They had lasered well, regressed
can I
well.
interrupt you, Dr. Shubhadra?
Yeah, okay, you
For
want
the
to
first
talk
case,
about the
as we
previous case?
agreed before, if there
Okay.
is any question from Dr. Singol about the first case, or Dr. Ahmad, both, or any from attendees they want to ask Dr. Shubhadra about the first case.
Actually, I can just make a comment if you let
Yes.
me. This is a very, very interesting case. I should admit that I have never seen a case like that. I was expecting to hear something about the thrombophilia, like protein C deficiency, as you have already told. But probably the pressure over the eye during the laser treatment, although it's not too much, but since the patient is prone to this because of the protein C deficiency, it's more open for these complications. Probably that, although gentle, but that pressure made it to become, easier to develop.
Yes,
But
I agree
you
to that.
managed
And
very well. Thank
yeah,
you.
yeah. So later we've seen some patients who develop hypema or little vitreous hemorrhage. So we always send them for testing. And some of them we have found to be, having more problem. We didn't have any dramatic like this, but now we are careful. If we start having some hemorrhage, then we know we need to test them.
And do you
Yeah,
have
I
the,
agree with
sorry,
Dr.
do
Singhul
you have
about
the
I'm sorry, go ahead.
long term? I mean, how the central retinal vein occlusion went after the first months? I mean, in long term, what was the prognosis?
Baby is good. She is doing fine. We gave patching because this I had a CRVO, so we gave patching 2 hours per day once the CRVO resolved over next 2 years. And baby is doing fine. There's no squint. There's no amblyopia. She's doing fine. She has little less vision on that side. I think it's 20/50 or something, and the other eye has some 20/40, 20/30.
That means that the thrombose has resolved totally, probably.
It completely went away with the
Yes, right.
anti-VEGF, and patient was already lasered. So I think both the things they acted.
Okay,
And
thank
then,
you.
of course, we corrected the systemic status.
Sorry, Ahmed, for cutting.
Yeah, we
No,
were
no,
lucky.
no, it works.
About
Yeah, I
Concerned about neovascular glaucoma developing in that.
yes, Ahmed, go ahead.
Yes, I agree with Dr. Singhul about the vitreous hemorrhage, and I've seen a couple of cases when I did the peripheral laser, extensive laser. There is some vitreous hemorrhage or hyphema that goes away totally on its own, but I haven't seen any case of CRVO, despite that this is, to me, in zone 2 to zone 1. Maybe I would consider from the start to give anti-VEGF, Avastin or Lucentis. Maybe this would decrease a little bit the laser in such case. I don't know if you agree or not, because I can see the
We were
laser
not
markers.
doing a lot of anti-VEGF at that point of time. We started anti-VEGF in 2007, but we are doing very little. That was before the AP-ROP study. So even today, we do now more for zone 1 disease. This was zone 2. Until stage 3, it was not very, there was not even much plus in this case. So we thought
that's good, because actually I presented in the EVRS in 2006 about the role of anti-VEGF in such cases of advanced ROP, especially in zone 2 and zone 1, even before the AP-ROP. But I had a few cases, 25 cases or so. Thanks a lot. It is very nice.
How many injections did you give Dr. Shubhadra for this? Only one and Avastin?
Say that
He
again.
did it.
Yeah. Did you give intravitreal injection for the baby, right? After
yes.
How
yes,
many injections?
dose.
Only one time you give, and what?
Only one time, and in 2 weeks everything went away.
Okay.
It was already lasered. We just added little more laser.
Okay.
The ROP had gone because we gave both the things. Okay, now I wanted to bring your attention to another rare entity which is not described in the literature. We described it for the first time. We had 3 cases. All of them had been lasered at birth, and they had regressed well and they were fine. And then they returned back with vitreous hemorrhage after 8 months to 8 years. So this is very unusual for lasered eyes, unless there was some fibrous proliferation or something. And we were very surprised. It was very difficult to photograph them, but you can see here. So there's a lot of blood in the inferior half. And under the microscope and under anesthesia, I found that they had very typical anterior hyaloid fibrovascular proliferation, exactly like you see in diabetic patients. You see this big blood clot in the periphery and filiform vessels at the ora base. And I could recognize it because I was doing a lot of diabetic vitrectomies at that point of time. And then we treated these, and this was unilateral. The other eyes did well in all these cases. So depending on the amount of vitreous hemorrhage, like the 8-year-old, he actually complained of floaters. And when he came in, he had 20/40 vision and fresh vitreous hemorrhage. And under anesthesia, then depending on amount of vitreous hemorrhage, we treated them with laser to the periphery or Avastin and anteretinal cryopexy. One patient who came with total vitreous hemorrhage, I had to do a vitrectomy and intraoperative cryo of the periphery. So, so this anterior hyaloid fibrovascular proliferation has not been reported after ROP. It has been reported after so many cases of diabetic vitrectomy or even without vitrectomy. So what we wrote in that paper was that it seems that the anterior retina grows. So two of these eyes I had myself lasered. So I knew that I had lasered well and right up to the aura. But I think if the babies are very small, if especially 25, 26, 27 weeks, when we laser them, then some of the retina is still growing and we don't realize that there's an anterior retina, which then is avascular, and maybe it is, giving out slow VEGF, and these new vessels are coming back only at the vitreous base and they don't come at any other place. There was no neovascularization at the posterior part or in the ridge area. And some of this we are now seeing in the anti-VEGF era, that, the anterior retina remains avascular, or even some of those eyes, you can see that some more retina has become avascular. So I don't know if somebody has seen these cases. In the literature, there are cases of little older children coming back with vitreous hemorrhage, but what they have described mostly is, NVE or fibrous proliferation within the laser marks. But all these cases, and after these cases that I reported, I have seen more 3, 4 cases. So it is not very common. We do thousands of lasers. It's a rare entity, but we should recognize this entity, and they behave exactly like the diabetic anti-highlight fibrovascular proliferation. So any comments, questions?
Okay,
Anybody has
thank
seen?
you. You have any comment? Anyone want to comment?
I think maybe this is more common, and this is what we should highlight as well, that in the cases that we give anti-VEGF, like Avastin or Lucentis, we should be following the patients because this is not exactly this. They will not behave like the laser. So usually we can see this more common with anti-VEGF, and we should be following the patient for longer duration. This is one. I've seen some of these cases, but not with laser, with regressed ROP. So without any laser, without any injection, sometimes later in life, you discover that there is some areas of avascularity and there is new vessels similar to diabetes. And you should always ask the patient whether they come in adult life or in pediatric age, whether they were premature and they were not treated, because this is a very known sign. So we should be aware of this. Thanks a lot for excellent case.
So this is another laser case I wanted to just highlight because there may be some residents or fellows there. So this was one of the first cases I saw. This was way back in 98. And this baby came with this, areas of avascular retina. And I thought there's no ROP, there's no ridge. And I did not laser on that day. And within 48 hours, when I called back, there were these flat new vessels. So the AP-ROP, which is now described, is sort of a futuristic definition. It says that, these patients will worsen, which means that if we see here, we have to imagine that this is going to become like this, and then we sort of call it AP-ROP. So I think the definition of AP-ROP does not talk about various phases of the disease. There's just one definition or description of AP-ROP. And today this child is blind. I lasered him after 48 hours after talking to some seniors. They said, oh, this is fulminate ROP. That time it was called fulminate ROP, type 2 ROP, you should laser. So I lasered, but I did not laser all these pockets. I lasered only the periphery. And today this child has stage 5 both eyes. So I learned my lesson that all these cases, we have to really go inside and treat all these avascular pockets. So this is an entity which is very often missed. This is one of the doctors who has written, he's drawn very nicely things, and then he's written, please come after 1 week. So what I want to highlight is that the classification does not tell us early AP-ROP. And how do we diagnose that is by the branches. So normal retina should dichotomously branch. So whenever we see that the branching is not dichotomous, we should think of AP-ROP. So here I'm just showing some cases of very early AP-ROP, how it starts. So you can see here the vessels were dichotomously branching, and then suddenly they started looping and forming these pockets of avascular retina. And this is in posterior zone 2. Same way here, the vessels were branching and then suddenly they started looping. And this will usually happen if the baby has suddenly developed pneumonia or anemia, or there was, uncontrolled oxygen. So the retina actually gives you an idea of what is happening. So I think that, the newer classification of AP-ROP should also have the earliest stages of AP-ROP. And if we diagnose them at this stage and treat them, then the results are much more better. And we published this in American Journal of Ophthalmology. So our results of zone 1 ROP were 87% with laser. Because we were diagnosing them quite early and treating them very early and not waiting for the classical stage 3 plus to happen. So I just wanted to highlight that how do we, what is our definition of something which is converting to a aggressive posterior ROP before it looks really aggressive, because once it looks aggressive, then the results will be much less. So anybody has comments on this?
Yeah,
Yes.
Dr.
Thank you, Subhadra, for emphasizing this, because AP-ROP is sometimes, difficult to understand for the unexperienced ophthalmologists, because they think that all these severe ROP cases are just AP-ROP, but it's not the same thing actually. As you have very nicely shown here, it's not, there's no white fibrotic ridge-like tissue here. So it's very ill-defined, as you have shown. So there are just branching vascular networks, but there's no fibrosis at the beginning. And mostly, since it's in the zone 1 or posterior zone 2, the peripheral part is just a choroid actually. And most of the inexperienced people think that it is just normal retinal vascularization. They may think that since there is no ridge-like structure, they may think that it's just normal retinal vascularization. So it's, it's missed by most of the people. So it's very nicely shown here, and it's important to discriminate between these two, because in AP-ROP cases, it may turn to stage 5 all in a sudden. So we have to be very careful, and we have to treat them very aggressively. And as you have told us that you are doing laser for these eyes. In those years, okay, but for now, do you do laser or anti-VEGF for these?
Yeah, so nowadays we do anti-VEGF, but there are patients we still have to laser, because we get referral from very remote areas. They are not going to come back every 2 weeks or 4 weeks for the next 1 year, and there's nobody locally. And as I said, with laser, we are having 87 to 89% outcomes even in zone 1 when we laser well. That is the caveat to laser well. And I just wanted to show this picture of what is laser well. So we've done here laser, and after 2 days, we call them after 2 days, and you can see here, this whole area is actually avascular. So when we lasered here, it was covered with blood. After 2 days, you can see if it is a white centered hemorrhage, that means it has regressed. But if it is still a thick blood, that means it has not regressed. And then you need to laser this whole area, all this area up till here. If you laser, then your success rate will be high. So I think the way we laser and the way we understand how to laser the zone 1 disease decides whether it's going to be successful or not successful.
I agree with Dr. Singhul that in our time, I think anti-VEGF would be the first choice in such cases. Maybe some augmentation of laser because of the remote area and not the regular follow-up with these patients. But if you can combine both the anti-VEGF and doing laser to the far peripheral avascular area, will decrease the risk of progression of high myopia and will decrease as well. It will allow with the anti-VEGF the spread of the normal vasculature to a more peripheral zone, and this will help the baby for the long term.
Yeah, this is one of my first lasers, very bad laser, but this is the learning curve. There's so much of skip area. So, so there's a lot of learning which happens. This is what I used to do when I was learning, but now this is what we will do, Very nice.
Yeah, confluent laser. So the term confluent laser, so you cover the whole area, no space in between.
Yeah. So coming to one case about anti-VEGF, so the very nice update by Krupas and Charan.
Is the last case, Doctora? It will be the last?
Yes.
Because we already exceed the time, and we have also...
So if the time is over, then I can stop.
No problem. You can go ahead with this one as fast as possible. Thank you.
Okay. So I wanted to show this case. He came at 7 in the evening to my OPD, pupil poorly dilating, quite a thick ridge, AP-ROP. So I thought this patient will anyway need anti-VEGF. So I injected anti-VEGF before going home and called him next day to do some laser, because that was the time we were doing combined treatments. And next day when he came, that is 16 hours after giving an anti-VEGF, his whole eyeball was soft. There were descemet folds. The whole eyeball looked soft and hypotonic. There was an exudative detachment, total detachment. And you can see these large choroidal infarcts. You can see there are lobules of infarcts of the choroid. And again, I didn't know what to do with this. So I had no idea. I have never read about this developing choroidal infarcts, exudative detachment. I have not done anything. And so the only thing I had was I gave betamethasone every 2 hours. I didn't know whether I can give systemic steroids. So I just gave topical steroids and tropicamide 4 times. And I said, let me think and you can come back after 2 days. And this is after 2 days, everything settled. The retina was attached, the ROP was going. But what I wanted to highlight is this rupture. So there was a tiny rupture here. And you can see within 10 days, the whole ROP went away, the detachment regressed. But after 2 weeks, the new vessels started coming back. And these new vessels are something which we may not see. They're very flat. They're having a hemorrhage around it. So, so when it comes back, it may be very subtle. So people are trying to do fluorescein angiography to see, these recurrence of the disease. But everybody does not have access to fluorescein angiography. And so because it was coming back, we decided to laser, and we lasered. And that area which was a rupture got closed with a vitreous condensation at that place. And so 2 weeks after laser, you can see everything settled. We were very happy. We followed till 3 months. And after 3 months, we told him to come after 3 months. And when he came at 6 months, his right eye had stage 5. So this eye, which looks so nice here, went into stage 5. Whereas the other eye, you can see all these subretinal exudates were there, but that did well. So combined laser and Avastin. So this case we reported as a choroidal infarct. In fact, if you look at the patients very carefully, we see a lot of these ruptures all the time in anti-VEGF eyes. Here's one patient, you can see here. This patient actually had a rupture which I had not noticed. It was in the fundus photographs. The first case of bilateral choroidal rupture after anti-VEGF was reported from Thailand. And once that report came, I went back and took out all my fundus photos post Avastin, and then I could see what I had not known before, that you can get these choroidal problems. And the reason in that paper, which is given, which still needs to be validated, is that the choroid also is immature. And we are not studying choroid in preterm babies. We are not doing OCT or ICG. We have no clue about the choroidal vascularization. And we are giving anti-VEGF. We know that anti-VEGF in adults leads to choroidal thinning. Reports are there that, if you give too much of anti-VEGF to AMD patients, they get more choroidal thinning. But really, what is happening to the choroid? Fortunately, in most of these patients, these ruptures are small. They are not in the fovea. They didn't cause anything. But I don't know if they will develop some break in future. But I have a number of babies who are showing these if we look for it. So when we look for these changes, they have been reported now in literature. And I did not laser this area. I don't know if that is the area that gave up. But yeah, so I'm just highlighting the choroidal complications of anti-VEGF treatment.
Do you think what is the reason behind these ruptures?
So
Because
it
of
is said that the choroidal vasculature in babies, preterm babies, requires VEGF, and it is immature. And when you give anti-VEGF, you actually create some problems there. But I don't know. Then it should be more widespread. But these are all very tiny, and they are not like you can say that they are in the area where the jet shot of the drug is going, because we are giving very tiny dose. And you can see they are of different shapes, different sizes. Of course, this was only one dramatic one where there was a huge amount of choroidal infarction. I don't know why it happened there. I suspect maybe because we are not titrating the dose to the amount of VEGF. We are just giving a standard dose to all the eyes, all the sizes. So maybe in some patients the VEGF is really high, and we suddenly shut it down, and it's just like there's a choroidal shutdown in this eye. So really, if we had some way of measuring how much anti-VEGF to give, so I suspect that disease was very fulminant when the baby came. There must have been very high VEGF there, and we gave anti-VEGF. This was half adult dose. So nowadays they say even 1/10 adult dose works. So we don't know what dose we are giving to what eye, what size eye, what VEGF. So I think this requires some more thought.
Thank you very much, Dr. Shbadra, for very interesting cases and unusual. Thanks for covering all this. We have two questions for you. One is about the first case. Have you changed your protocol for ROP during the COVID-19?
So during COVID-19, we are not testing the babies for COVID. We are taking, as I said, standard precautions. We are treating every baby and every mother as a COVID suspect. So the Indian ROP Society got together and we set up some guidelines. These are on our Indian ROP Society website. If anybody wants, they can email to me or they can directly download from our website of the Indian ROP Society. Basically, what we've done is we've increased our follow-up a little bit more for the low risk cases. Like if we were calling it 2 weeks, we are calling it 3 weeks. If we were calling it 3 weeks, we are calling it 4 weeks. For the low risk cases, for the high risk cases, if we were following, we now laser. So we've sort of relaxed our laser criteria. So if it is 2+, and sometimes we may think that, okay, we'll call after 1 week and decide. So those cases we may be doing laser or anti-VEGF on that day only. So on both sides, we've sort of reduced the follow-ups, and we are analyzing our data whether our strategy led to any harm.
Okay, we have many questions, but I will keep to the end because we already exceed the time. So we will have Dr. Singol talk. Then we can answer this question, the other questions at the end of Dr. Singol presentation. Now I will introduce second speaker, Professor Dr. Singol Ozdik, a consultant ophthalmologist, VR, Gazi University, Ankara, Turkey. Thank you, Dr. Singol, for being with us, and please go ahead.
Thank you, Mohammed. I would like to thank you first for your invitation and for making all these things, putting them together. And I'd like to say hi, Selamun Aleyküm, merhaba to my friends. And I will try to talk about more on the surgical cases after Subhadra's very didactic and nice cases. So I will just talk on stage 4 cases first and 5, and then scatricil and one adult ROP case if we have time. And we can make discussions at the end of stage 4 and stage 5 and then scatricil if it's possible for you. So this was a stage 4A case. This was a premature baby and he had bilateral anti-VEGF injection. And as you have seen, it's in posterior zone 2 probably. And as you have seen, it's 360 tractional retinal detachments, stage 4A. And it occurred as the doctor, the previous doctor, the referring doctor said, occurred all in a sudden. So this is very typical in such ROP cases if the fibrovascular component has already started and if you inject the anti-VEGF in that age, which is a little bit late actually, then it may cause some contraction, which is the advanced type of this is called as crunch phenomenon, leading to stage 5, peculiar type of stage 5 retinal detachment. So what we do is we do lens sparing vitrectomy if possible, as soon as possible. And after the surgery, you see that the retina is totally attached with very little fibrotic component left. I just want to, so this is our normal routine vitrectomy. We do just central vitrectomy, try to do posterior highlight removal if possible without insisting on it, only in the posterior pole area, and remove as much fibrotic tissue as possible to relieve the tractions and do the laser in the avascular area. So I just want to share you another interesting case. This is another stage 4A case. She was referred to us at the 37th week for stage 4A. And he had again bilateral bevacizumab injection 1 week earlier for zone 1 disease. You see, this is right eye and this is the left eye. As you see, there is tractional retinal detachment, although you don't see it in 3D, but This part is elevated, highly elevated, and you can see that these parts are just choroid. As you see, you can see some vessels, but these are choroidal vessels. And it's very difficult to see the border between, in between the vascularized retina and avascular retina in the temporal parts. As you see here, it's actually somewhere here, but it's difficult to see. And in the nasal part, since it's contracted, you can easily differentiate the vascular and avascular parts, but in the temporal part, it's very ill-defined. And after this, you can say that it's in zone 1, even maybe zone half disease, something like zone half disease. And during the examination, you can see this. You see, this is just choroidal vascularization, no retinal vascularization. It ends like here, the retinal vascularization. So the zone 1, even the macular temporal macular vascularization is not complete. So what should we do for these eyes? Of course, we should do vitrectomy for these eyes, and we always try to spare the lens, try to do the lens sparing vitrectomy, as you see here. Now you can understand a little bit more that it's very highly elevated actually in these parts, and the ridge is very vascular, highly active vascular disease, as you see here. And the nasal part, the vascularized nasal retina is almost totally come over the optic nerve head area. So what we do is we just do the central vitrectomy, try to remove the posterior hyaloid, at least in the macular area, in the posterior pole, and try to cut the connection between the optic nerve area and the ridge area, so that it doesn't continue to contract and cause more traction in the nasal retina, causing more retinal detachment. After cutting this connection, we feel much free. You know, we always try to avoid forming a retinal braid. So we continue as we feel safe. If we don't feel safe, just leave it alone. Leave the fibrovascular tissue if you cannot remove it. Then since these are very highly vascular, active vascular, we may need to do some cautery to the tips of the neovascular tissue, but not to the retina, and do laser. Should we laser the whole, and this is the other eye, and should we laser the whole avascular area? Because it's almost in the macular area, in the temporal part. I would say no. This is the fellow eye, other eye. I have done something else. I have I did the same thing, remove the posterior hyaloid in the macular area. And this is the better eye, as you see the left eye. And then I started to do laser, but not to the whole avascular area, but left some parts in the zone 1. I did the laser in the zone 2 and gave some anti-VEGF at the end of the surgery. By this way, I just wanted to let the eye gain some vascularization, at least in the zone 1 area. And as you see here, this is just 2 weeks after the surgery, and this is 6 months after the surgery. Although she has already quite high myopia, but you see retina looks quite nice. And we have seen that retina was vascularized even in the nasal part, where we have left without laser after anti-VEGF injection at the end of the surgery. So these are very peculiar cases actually, but we can use anti-VEGF as an adjunct to surgery and laser in zone 1 disease when there is stage 4. And I have found a very new publication on this, although we have done these surgeries very earlier and we are collecting our data. So this is kind of approach in such cases to have some more retina without ablating. So this was the stage 4A cases. If you want to comment on these cases, we can comment, or we can just continue with stage 4B.
Yeah, Dr. Shubhadra, if you want to ask or comment about these cases, or Dr. Ahmed.
No, I don't want to ask. I agree with that. Only, did you cauterize the ridge?
Just only the bleeding parts. I try not to touch, but when it bleeds and if it doesn't go away with the pressure elevation, I just touch to the tips of the elevated parts, not to the retina, never, because it may cause retinal break formation, which will be a disaster.
And what you did, that's exactly what we also do. But sometimes if the very anterior part I cannot laser, then I do put some cryo marks there, or I have to do with an indirect ophthalmoscope. So sometimes with the endo laser, I may not be able to reach right up to the periphery in some cases.
Right, right. Okay, thank you. And
Ahmad, you want to have any question, comments?
No, it's excellent. I don't have any comments.
I have a question, Dr. Singol. Do you prefer maybe to give the Avastin only 1 day or 2 days before the doing the surgery or after the surgery after you have done?
For
Does they
this
make a
case,
difference?
not, because she already had anti-VEGF injection before sending it to me. And probably it caused that type of contraction. But if it is a very highly active disease before the surgery, and if I feel that it may cause postoperative hemorrhage, then I do injection just 1 day before, not too much. Just one, maybe at most 2 days, not more than that, because it may cause crunch retinal detachment in those eyes. You shouldn't wait, just 1 or 2 days before. And it may help to prevent retinal vitreous hemorrhage, post-op vitreous hemorrhage. So when we continue with the stage 4B cases, this is a stage 4B case. The right eye was already stage 5, as you have seen here. And the left eye, this was the better eye, left eye. And you see that the posterior pole is totally collected with the membranes, and the vascular arcades are coming together. So what we did is just surgery, of course, again, lens-sparing surgery, lens-sparing vitrectomy. I always open the conjunctiva and put a suture in the infusion area. And as you see here, we do just vitreous, central vitreous clearing. And then I always use posterior, to peel the posterior highlight, I always use triamcinolone and try to peel as much as possible. And we have to avoid from retinal break formation. So less is better than having a complication. So we always try to be as conservative as possible, but try to remove as much fibrovascular tissue, to remove as much fibrotic tissue as possible without causing damage to the retina. So as you see here, it's some kind, it's not a typical stage 4, I should say stage 4B, but you see there are layers of membranes. It's not in the in one area, I mean, starting from the ridge area, but it's all over the posterior pole. It's kind of atypical, but you see that the macula was a bit opened with these maneuvers, and it was going towards the periphery in the imperotemporal and superotemporal quadrants. And after clearing all those things, the temporal retina was avascular. We have to put laser to that area, and I leave the eye always in with air, and I always suture the sclerotomies in pediatric, I mean ROP cases, although it's 25 gauge. So what was the result? This is the result, an 18 months follow-up. The macula was completely clear, quite well, with lasers, and this was the pre-op and this was the post-op. So my main message for these cases is try to be conservative during surgery as much as possible. You can leave the ones that you cannot peel, and you shouldn't risk the retina to have a retinal break. Another one, stage 4B, the other eye is again, the fellow eye is stage 5. And this, we had to do a lensectomy vitrectomy, because as you have seen, retina is just at the back of the lens in the temporal area. So I had to do, I tried first to preserve the lens, but I couldn't relieve the attractions in the temporal periphery. So I had to do lensectomy. And then since this was the only eye, and I had to do membrane peeling in those areas and do laser, and at the end we could reach a retinal like this. Although macula was ectopic to the temporal side, the angle between the vessels are not bad, and the retina is attached, although highly myopic, but the retina is attached. Another 4B case, as you see here, again, you see the straightening of the arcuate vessels and narrowing of the angle. And after the surgery, you can reach to this picture. So I would like to say that perfection is the enemy of good, which is the, Voltaire, by Voltaire. So you should stop when you feel unsafe and do not risk the retina. And iatrogenic retinal break is a very bad prognostic sign for these eyes. And if you have a retinal break, like in this case, this was again another stage 4B case, you see there were hemorrhages under the hyaloid and membrane, fibrovascular membrane. So we have to peel the posterior hyaloid, and during peeling of that posterior hyaloid, we had a small break in the inferotemporal arcade, outside the inferotemporal arcade. What I did was, I just peeled the posterior hyaloid. In this area, try to peel a little. You cannot peel all over, but at least in the area of a retinal break, then do laser. There was a small area of retinal detachment around it, and then just gave some gas. And this was the post-op. So if it is in a silent area, I mean the retinal break is in a silent area, you can achieve a result like this. But if it was in the most proliferated area, in the rich area, you couldn't do that. If I had a retinal break in the temporal area, in this fibrovascular area, I would try a buckle, maybe a localized buckle in that area, which may help. But when you have a retinal break, the success rate is really very low. So parameters affecting the outcomes in stage 4 ROP are, the positive parameters are, if the patient has already an peripheral laser done or some anti-VEGF to prevent the post-op hemorrhage, and if you can do lens-sparing vitrectomy, and if you can surgically induce the posterior vitreous detachment in the posterior pole, these are giving good results. And if you have a pre-op bad plus disease, if you have a post-op vitreous hemorrhage, or if you have an iatrogenic retinal break formation, and if you need to do lensectomy, which is very important for the post-op visual rehabilitation, these are negative, effects. These have negative effects, and we have published this in British Journal 2 years before, and our success rate is like 90% in stage 4A and like 60 to 70% in stage 4B cases. So, do you have any questions or comments for the stage 4 before stage 5? Can you unmute, Mohammed? We can't hear you. We can't hear you, Mohammed. Can you unmute yourself?
Yes.
Okay.
Yeah, I'm sorry, because I'm reading the question at the same time. Do you have more to present about stages, another stage 5?
Yes, I have some stage 5 after this.
Okay, because we are also over the time. If you can give one case in stage 5, okay, then we can go for discussion.
Okay, very good. So this is a question about stage 5. Should we operate them or just leave them alone? Because we have very, very low visual expectations, just preservation of light, or maybe a little bit ambulatory vision is our main, aim. And even if we don't have these, we can have some cosmetic or anatomical purposes by doing surgery. And usually, if the fellow eye is good, mostly the stage 5 eyes are not operated. But I should say that stage 5, not all the stage 5 eyes are the same. They should be further graded. I think that the total shallow open funnel stage 5 is not the same as the stage 5 with total leukocoria or a closed funnel one, or with the corneal lenticular adhesion with the corneal opacity one. So they are not the same. So I think they should be graded, further graded. And for as an IC-ROP group is working on this project to make a further staging on stage 5 cases. And for me, total shallow retinal detachment, which is ophthalmoscopically observed as in here, can be staged as stage A, or if you have total leukocoria like stage 5, it's stage 3B, 5B, or if you have a corneal lenticular adhesion causing corneal opacity, it should be like stage 5C. So let's come why I do want to do this. This is a stage 5B with total leukocoria type retinal detachment. As you can see, what do? We almost always do lensectomy. We can try trans-iris route or limbal approach, or if the peripheral retina has already been lasered before, then we can still try a little bit posterior entries. But what we do is we try to remove the fibrotic membranes behind the lens layer by layer very patiently. And when you do that, you will see that the retina is going backwards. When you relieve it, it goes back if it is not too late. I mean, if it is not a very old stage 5 case, you can see that you may even see some retina at the back, maybe a little bit attached parts. Even you can see this. And I always leave the eye with the air, as you see here. It helps to close the sclerotomies also. And as you see here, you can have a visual like counting fingers, or even you can have, if it is a stage 5A, an earlier case, like 0.05 vision after such cases. And this is a bilateral stage 5 case. At the beginning, we just operated on the left eye, and the right eye went like this with the corneal opacity, and the left eye, as you have seen, it's very well preserved. Even for the anatomical or cosmetic purposes, it deserves to be, operated for me. And for the scatricial cases, it's sometimes more difficult to decide on to operate or not to operate, because the retina may be detached since neonatal period, or it's detached afterwards. So we are not so sure. For example, for this case, this was a 6 years old baby boy actually, and he had previous bilateral anti-VEGFs, lasers, cryotreatments, multiple in elsewhere, and now this is the better eye, and with 0.1 vision. You see there's fractional retinal detachment. This is a scatricial case, and macula was, ectopic in the superior temporal area, and you see these parts are total fractional retinal detachment in the superior part. But if we do the surgery, you will see the result. If we don't do the surgery, during further life, these fractions may cause even rhegmatogenous retinal detachment and may cause the loss of this eye. You can put a scleral buckle at least, but it's possible if you can see the anteroposterior traction, which can be removed, not the tangential ones, because it may be difficult to remove those things, and it may jeopardize the retina to have a retinal break. But for such cases, it's really removal. It looks removal, so you can try vitrectomy. And this may be the result. So vision improved from 0.1 to 0.3. This is a huge increase for such a case. And retina looks much better. So even for scatricial cases, you may think about doing surgery. Another 13-year-old girl, again, almost leukocoria-like thing. And with the surgery, we could open the funnel, and I will show the result. As you can see, there is a retinal fold, but she has a little bit of ambulatory vision. I do operate this case because she already has some hand motions vision already. if she doesn't have any light perception or nothing, I wouldn't touch, of course. But since she had already some hand motions, then we could have some ambulatory vision. So that's it. Maybe I can show, if we have time, within 1 or 2 minutes.
We have already exceeded the time, maybe at the end if we find the time. So
Okay.
we have many questions now.
Okay.
Thank you very much for an excellent cases, interesting. We have actually a live questions. Mr. John, if you can open, you can see who is available. Dr. Nadeem Al-Hussein. Dr. Nadeem, if you want to talk with us, please. So we will have only about 10 minutes for all discussions and first live.
Mohammed.
Yes. Hello, Dr. Nadeem. You are with us, please. Yes, go ahead.
Yeah. I'm in the.
Hello. Yes, Dr. Nadeem, we cannot hear you. Can you please go ahead? Okay. Can you go for another, please?
For me? You mean you're asking me?
No, we are having a live questions, Doctora.
Okay.
We will have Dr. Muhammad, Dr. Al-Bulini. Okay. Can you open for Dr. Al-Buluni?
Yes.
Hi, Najmul. Nice to see you. I can see your photo.
Yes, Dr. John. Anmar, if there is no, can you have Dr. Muhammad Malik or Maliki maybe? Anyone? So meanwhile, you open for anyone you find, John. I will have these questions. This also, you can hear him. Okay, there is a question for Dr. Singol. Do you use a 27 gauge system in babies?
Actually, I don't have the 27 gauge system, but if I had, I could try, but I don't have any experience. But we can use any gauge vitrectomy setting for ROP cases. Actually, I have seen by use of 19 gauge by Dr. Tracy and Capone also with the infused cannulas, and I'm using 25 gauge for my cases, but 23 or 25, 27, any gauge can be used. The main principles are the same actually. So when you apply the main principles, it's not a big issue, but of course we try to make the incisions as little as possible, but 25 or 23 is quite reasonable for me. And I also use the spacers for the trocars because these trocars are made for adult cases. And although Alcon has some and also Neely Dork has some pediatric trocars, I put a small piece of scleral buckle. We use scleral buckles. A small piece of silicone can be put to the bottom of the trocar so that you make it smaller for the small eyes. It's a spacer. I use it usually routinely, and I have shown it in one of the videos, but I have forgotten to point it out.
Okay, do you use triamcinolone for VHF removal?
For posterior hyaloid, I guess,
yeah.
Yes, I always use it, and for many times, not only for once. I give it, clear the vitreous, and then trim the vitreous as much as possible, and then give it again and again to see if I can remove more vitreous. So I do.
This is a question from my dear friend, Dr. Saad Wahib. If you plan a vitrectomy, do you use anti-VEGF before? We have question this one, and you answer.
Yeah.
Maximum 2 days, right?
Mm-hmm.
Yes,
okay.
Dr. Singo?
Yes, we have already answered that question, I guess. There is another question here.
What is the prognosis for stage 5 ROP in your experience?
If it is, it depends on the case, as I have told before. If it is a fresh stage 5 case, where if it is not a closed funnel, posterior, anterior closed funnel, and if it is not, you know, associated with corneal opacity, we can have some ambulatory vision. The best one that I have had a 0.2 vision with stage 5. But most of them have light perception, hand motions, if everything goes well, or some ambulatory vision, if we are lucky, but it's not too much.
Are you using regular trackers for ROP surgery?
Sorry, I couldn't.
Are you using regular trackers for ROP surgery?
Yes, I do, but I use just spacers to the trocars, as I just described before.
Okay, do you have any experience with aflibercept in ROP? Iluvien?
Yes, I do. Yes, I do have. Actually, all the anti-VEGFs work well if we are using, you know, pre-op. But what I prefer is, since the ranibizumab, the systemic absorption of ranibizumab seems less, at least theoretically, I prefer ranibizumab. But I have used all three anti-VEGFs in my practice.
Okay, maybe this one. What about scleral buckling in these cases, stage 5? You already also talked about.
In stage 5, I always never use, you know, scleral buckle. But in stage 4 cases, since you have just peripheral unrelieved tractions, I can put scleral buckle as a, you know, as an adjunct to vitrectomy, not only for the primary approach. I usually do vitrectomy first, and if I feel that I need an additional buckle, then I put it. Because when you put the scleral buckle, you have to remove it within 6 months or so. It can, you know, support for some time, but it's not my primary approach. But for stage 5 eyes, they are usually already collapsed, so scleral buckle do not help much.
Okay. We have now a several questions for Dr. Shubhadra. In the first case, Dr. Shubhadra, regarding aggressive posterior ROP, as it is extremely rare to have central retinal vein occlusion in this age group.
Yeah, I actually wrote the answers for all the questions. So I don't think it was aggressive posterior ROP because I have shown the slide of the other eye. It was a stage 3 staged ROP. Pupil was fully dilating. And actually, it was not a very severe ROP. You know, severe ROPs we don't give to our fellows to do lasers. We do them ourselves. So this was a very mild case. And it was definitely not an AP-ROP. If you see, there was no configuration abnormal of the vessels. They were all dichotomously branching. And the other eye I showed after laser, we just did a peripheral laser. It went off well. And this eye also, we did just a peripheral laser. So there was no AP-ROP. Actually, I've lasered a lot of AP-ROPs, but I didn't see CRVO even in those cases. As Dr. Ahmed said, sometimes we get little vitreous hemorrhage or little hyphema in those cases, but really not a CRVO. And this was not AP-ROP at all.
Okay. There is another question. How far from limbus you are injecting the premature babies? Is it 1.5 millimeter?
1 millimeter from the limbus, straight vertical down at 9 o'clock position in both the eyes, because that is the place where we have maximum space.
Only 1 millimeter?
1 millimeter. I do my surgeries also at 1 millimeter.
Because he's mentioning the one who is sending the question, it is written or is a reference is 1.5.
It's fine, like 1.5. I don't think there's much difference. I do at 1. I do suture-less vitrectomies for all my cases, 23 or 25 gauge. I also used to use 19 and 20 gauge, but now I do suture-less 23 gauge.
Okay. The last questions is, do you repeat Avastin injection if it is, what is the minimum interval?
I have never repeated anti-VEGF except for the surgical case. Like Sengul showed that, sometimes they come back with vitreous hemorrhage or hyphema after a few years. I might inject at that time, but primarily if the disease recurs after anti-VEGF, then I would add laser, or most of the cases, of course, we do combined because they may not follow up. So we don't do monotherapy. We do combined treatment.
Okay, we have another question. Maybe we can keep till the end of the all sessions. If there is anyone in live, he want to talk, Mr. John. Anyone available before we can go?
Yeah.
Is there any live person who want to talk? Um, so I will start giving my talk. My talk, it will be very fast and very short because so we can have a time for discussion. This is just a review of the retroideal study that was done in Germany. By the way, this study is presented at Euroretina September in 2017, Barcelona. Um, in this study, what is the impact of ocular comorbidities on outcome? So the aim here is to see the effect of the Iluvien in a patient they are having an ocular comorbidities. This is actually a retrospective analysis of Iluvien treated patients. The number of the patients they are involved in this study, it was 81. From 81 eyes with from 63 patients, and diagnosed with DME about and follow up about 30 months. Study design of this study is retrospective, as I mentioned. It's a multi-center study performed in 16 center in a German. They are having an inclusion criteria for this patient to be included in this study. They are 100% people they are involved. They are insufficient response to anti-VEGF. So they are 100%, all of them, all the patients included in this study, they are having insufficient response to anti-VEGF before. They are about in 75% of these patients, they are having a recurrent or persistent macular edema. In about 32% of this patient, they are having no reaction or any visual improvement to the previous treatment. And there is no reaction of visual activity in the pre-treatment. There is also in 30% of patients, there is high number of recurrence during the pre-Iluvien phase. What is the outcome, what they are looking after from this study? We are looking to visual acuity improvements in of these cases. Central, yes. Central macular thickness, if there is a central macular thickness drop, incidence of intraocular pressure elevation, sorry, and incidence of cataract extractions. So this is the outcome they are looking for. In this case, they are treated with Iluvien. They are having the patient, they are having ocular comorbid. Patients, this baseline characteristic of this patient, the mean age of this patient, they are 66 years, but in a 48% of them, they are above 70 years. So the mean duration of DME, it was about 3 years. The lens condition, pseudophakic, they are represent about 75% of the this group patient, they are pseudophakic. Previously vitrectomized in about 48%. They are having a multi-treatments, different type of treatments for DME before we include them in having Iluvien, laser or ranibizumab, aflibercept, steroid, ivermectin or dexamethasone. There is some patient they are having also they are taking an anti-glaucoma treatments. In about 18% of these patients they are already on anti-glaucoma, and the mean range for follow-up it was for 13 months. They are doing a subdivision for this group into two. They are divided into two groups. There are prior vitrectomized. There are some patients, which is about in 48% of this patient, they are already vitrectomized before they are using Iluvien. So others, which is about 51, or you can say 52, they are already non-prior vitrectomized. And in those they are non-prior vitrectomized, they are 69%. They are having a cardiovascular disease. This is, you have to check also these comorbidities, also systemic. And in those they are prior vitrectomized, they are also cardiovascular disease. What are the non-prior vitrectomized? How they are dividing these groups? They are prior vitrectomized and non-prior. In ocular condition commitment disease, they are available. In non-prior, they are in 21%. Pseudophakic, they are in 70%, 66%. They are having, they are pseudophakic. Cataract, they are in representing about 28%. In those, they are non-prior vitrectomized. And ocular hypertension, 10%. They are using a medication for lowering IOP in about 17%. And macular ischemia present in about 3 or 4, you can say 4% in non-prior vitrectomized. While in those other division, other subgroups, which is prior vitrectomized, they are having an ocular concomitant disease, 51%. They are pseudophakic in about 85, and cataract in 15%. They are representing 15%. They are having cataract. Ocular hypertension, they are 28, and they are using anti-glaucoma, 23% of them. And macular ischemia, they are higher. It's about 12 in comparison to non-prior vitrectomy. Also, they are including another comorbidities, ocular comorbidities, which is a grade of diabetic retinopathy. We are here concentrating about the significantly more in BDR. You can see here in the figures that BDR, they are very high, and those they are prior, priorly vitrectomized. So those they are having a vitrectomy, they are having more BDR. Now we will come to the result after we are having these patients, and they are having all these kind of ocular comorbidity. So is the Iluvien we're going to do and have an effect? If you look to the, as we said, the outcome, visual acuity, it was changed from the baseline about 4 letters. There was an improvement. We are talking now about patients. They are having a visual, the ocular comorbidities. So there is an improvement about 4 letters. This is an average, but there are some of the others, they are having more. And it was significantly, it continued during the 30 month or 34 months, they are, or 56 month follow-up, they are having a stable visual acuity improvement. Regarding the central retinal thickness, the main change from the baseline, also there was a drop in drying of the macula from 500 to about 300 and about 300. And this one, it was shown here in the paragraph. That means there is an effect of drying the macula in these cases. And it was shown that 2 out of 3 eyes had a central retinal thickness less than 300 at a month of 30 in both groups. If we look for the safety outcome from the looking from the safety regarding the intraocular pressure or the cataract, this patient they are followed in both groups, that there is a little increase in the intraocular pressure, about from 15 to about 17 or 18. In average from 15 to about 15.6, which is very, very less increasing in the intraocular pressure. But if we subdivide these patients and sub-analysis to all patients, we are having an increase of about 30 millimeter mercury, about 12 or 7%. IOP treated before giving Iluvien about 22%. IOP treated with after Iluvien, they are only 27. And overall, IOP treatment all about is 49%, or you can say 50%. So intraocular pressure surgery is it's already, or you can say 3.7, and we'll do a comparison with FAME study. If we do now just a comparison between the FAME study and the retroideal study, you will find that IOP increase more than 10 millimeter. They are less in comparison to the FAME. IOP elevation above 30, they are also about less in about 50%, if you can say difference between both. Emergent IOP lowering medications, also we don't have a lot. We are having less in comparison also to FAME. Cataract extraction almost similar. In outcomes regarding the visual acuity, that you will find that the gain in both FAME and the retroideal study, it is almost similar, plus 5 letters. And in about more than 15 letters gain, it is less in retroideal study, and this can be explained because of this ocular comorbidity. But overall, there was a stability in both retroideal and FAME study. A central retinal reduction, it was seen almost similar. So here in retroideal, all IOP-related values, it tends to be lower than FAME. Good agreement between the study that Iluvien was effective in sustaining long-term stabilization, improvement in visual acuity, improving during the macular, and this is the outcome and the result of this retroideal study. Thank you very much. If there is any questions, we will go for that. Otherwise, we will have maybe Dr. Ahmed presentation, then we can have a discussion. Dr. Ahmed, if you can start, please.
Ahmed, which Ahmed?
You are the only. We agree that you will do Ahmed Al-Khashab.
No, Salam.
Ahmed, he is a very poor guy, and he wants to be all the time the last. You see, he's very kind.
Yeah. So I'll start sharing my screen. I'm sorry. Yeah. Okay. So I'll start first talking about advanced PDR and vitrectomy in such cases. I'll share some of my cases. This is actually a 28 years old female patient, insulin dependent for more than 13 years, uncontrolled hemoglobin A1C 11.7. The visual acuity at presentation was 2400 and 2150 in the left eye, clear lens, and advanced PDR. This is the image on presentation, and as you can see, fulminant neovascularization and extensive traction, as you can see here in the OCT. So there is some element of foveal herniation in the right eye and extensive traction. So in this condition, the surgery is the only solution for this problem. And we can see here the vitrectomy. In this young age, I did not do any combined procedure of phaco-vitrectomy, core vitrectomy initial, and then starting to do postehyaloid sealing, but there was taut postehyaloid. And because of the traction on the fovea, I opt to use a bent 27 gauge. I usually use 25 gauge vitrectomy. So this is a bent to 27 gauge needle. And I release the postehyaloid from the fovea and then extending this fibrous and postehyaloid membrane amalgam to remove it centrally and extend this peripherally. And despite that, I gave anti-VEGF 3 or 4 days before surgery, there is some hemorrhages from the points of traction. And you can see here with just the cutter confocal removal of this fibrous proliferation and membrane, we can be able to remove it all. I usually opt to use higher magnification to see exactly and to be able to delaminate the membrane very close to the retina without causing any iatrogenic holes or tears. I usually try not to do excessive diathermy, but bleeding points which are persistent, I always try to remove and close. ILM peel, I think, is crucial in these conditions. And whenever I'm doing ILM, I'm trying not to pinch too much. I'm trying to have the ILM as one sheet. So whenever it started to fragment, I peel the everted or the inverted flap to create this continuity of this ILM peel. In this condition, actually gas, I usually prefer gas than air in such cases. And when I'm using, I use SF6 15 to 20%, which is more than enough. And then clearing any residual vitreous hemorrhage, any fibrous tissue can be removed totally, and then laser augmentation and gas. And this is the post-op image, and with time we can see this is the image post-op of the right eye, and even the foveal contour starts to form. This is the last image, and we can see the OCT angio of this case. There is no distortion of the vessels, even in the foveal avascular zone, and the vision improved in this patient from 2400 to 2025. And she didn't develop any cataract. This is the second eye of the same patient. This is after the injection of anti-VEGF, and we can see there is extensive traction that was present, and for which we did as well a similar vitrectomy. I will not go through it because for the sake of the time, and I think we can go through directly to the this case just to show extensive cases. This is a patient who lost her vision in the left eye after a prior vitrectomy and the oil in the left eye in another country, in her own home country, and she did phaco plus IOL in the right eye 2 years back, and she came to me with this image. I cannot see prior to surgery. I was not able to see anything because there was extensive vitreous hemorrhage, and I injected 3 days prior to surgery anti-VEGF, and then this was the image during surgery. There was extensive fibrovascular proliferation and vitreous hemorrhage that was cleared initially. And in these cases, I usually trim the vitreous peripherally 360 degrees to gain access to the central area. Initially, I was thinking that I would need bimanual technique, but because the retina was so fixed, it was not mobile, highly mobile. So I managed with just unimanual, just cleaning all this fibrous tissue in front of the retina. Just with the cutter, you can see the direction of the cut, it's always up. And whenever I see that I'm causing excessive traction on the retina, I leave this area and move to another space, not to create excessive traction on this point. And then I will return back again. So segmentation, so that you can gain access to the fibrous proliferation. There was repeated hemorrhage covering the macula, so I usually do not give it a long time to remove it so that it will not form any membrane. And you can see here, just cutting with the cutter, you can remove all the epiretinal membrane. and clean it all without any need of bimanual technique, because the retina was not highly mobile. And you can see here moving from one point to the other and gaining more and more access to the delamination area. And this is the post-op image. The vision improves from counting fingers to 2200. There was extensive RPE changes, but the vision is definitely much better than before. This is another patient where I opt to use a bimanual technique. This is a 42 years old female patient, insulin dependent, hemoglobin A1C 11.7, and the vision was 2400 in the right eye, counting fingers in the left eye, and there was nuclear sclerosis, so I did a combined surgery. You can see here in the right eye the elevation of the retina. And this is the image prior to surgery. And with the autofluorescence, you can see the extent of the subretinal fluid involving the fovea. And this is the OCT initially, and then 1 week before the surgery, you can see the whole macula and the whole fovea is totally detached. This is the surgery, initially done the phaco. I usually do not need to put any sutures because I'm opening 2.2 opening sclerotomy, and I feel that it is stable as long as the lens is well covered by the rexes. Again, the same technique. I'm trying to remove the vitreous altogether peripherally. And I think anti-VEGF prior to surgery can add in this, not only to decrease the hemorrhage during the surgery, but as well cause some element of traction anteroposterior, so cause some element of separation of the peripheral posterior hyaloid. So you can gain access all around 360 degrees. If there is continuous sheet, I leave it, and whenever I will finish removing the epiretinal membrane, that's the time that I can be able to tackle this posterior hyaloid. This was an extensive sheet, and this retina was highly mobile, so I prefer to use bimanual technique. And this is a not edited video, so this is the real time, maybe fastened a little bit. Always see if there is an element of extension of this fibrous proliferation, because sometimes there is a sheet which is very maybe not well seen, not highly fibrotic like the other sheet. And removal of the fibrous proliferation, just cutting. Whenever there is bleeding, I stop just to allow this hemorrhage to stop or to clot, and then maybe start again at the same point or a different point, now elevating the membrane and gaining more access to any points of traction and adhesion. And as you can see, now we can manage even the area with previous or prior bleeding or hemorrhage, and then elevating the membrane. One more point, which is very important to mention, when we are removing the epiretinal membrane, do not pull too much on the membrane, but the aim is to gain access to the points of adhesion, as you can see here. That's the main aim. So do not pull too much, and the direction of the pull of the epiretinal membrane will allow you to gain better access. As you can see here, this is I changed the direction of traction to have a better access of this more peripheral or more distal points of adhesion, and then reversing back again to gain more access. So not one direction of pull. So you are doing using both hands to gain a better access of the epiretinal membrane. And once you can do this, once it is large sheet, I think it is better just to remove it with the cutter. And if there is any residual membrane, you can gain access with either the cutter, or if you need the scissor, you can introduce it once again and peel the remaining epiretinal membrane. As you will see here, I will just remove the remaining epiretinal membrane with the scissor once again, despite the cutter can be enough in this condition. It is not essential to remove all epiretinal membrane, although I usually prefer to do this, but at least not to leave any areas of continuous traction, any sheet of continuous traction. If only points of fibrous proliferation, you can leave it and maybe dithermize, it will be more than enough. But here, you can be able to remove all the epiretinal membrane without any problem. So all the epiretinal membrane is removed. I think in this condition, now we need to do ILM peel because of the extensive traction that was on the fovea. So to allow this fovea to return back in place and to remove all the traction on the fovea. And again, the same technique is to remove the ILM all in one sheet. Try not to have piecemeal. Whenever it started to be very small piece, stop and take the other edge and peel it in the other way around, and extend the ILM peel to the maximum as much as you can, so that to decrease any traction and to allow this fovea to return back in place normally. And in this case, I put only gas, and this was enough. And I was considering actually to leave some ILM in front of the fovea, so I trimmed all the ILM and like a foveal sparing ILM, but I felt that there is maybe some hemorrhage on the fovea, so I pulled all the ILM to remove any residual fibrosis that can occur on the retina. And this was the post-op image of this eye, 2050. And this actually hype remained for a long time. I've just seen the patient 1 month ago, and there was this elevation. This is the other eye, this extensive traction, rhegmatogenous retinal detachment. So you can see the whole retina is highly elevated, and the same technique was done. Combined procedure as well. And we can see here, again, removal of the posterior hyaloid, first all around 360 degrees. Gaining access to the membrane in a better way, then using the cutter to decrease the traction in between areas, but we can see that this is a whole amalgam, so you cannot gain access underneath it without the bimanual technique. So here started bimanual dissection and moving from one place to the other, and here we can see the differentiation between when we have traction retinal detachment and traction rhegmatogenous retinal detachment, where the retina is highly elevated. So moving and without causing extensive traction on the retina or more elevation of the retina is crucial. One point to the other, and then moving to the area where there was the initial tear, there was a large sheet, so you cannot gain access underneath all this area to segment it first and then move to remove it piece by piece. And this is near the end. And again, in this condition, despite that the retina was highly elevated, I think we can go with ILM peel with or without PFCL. So making the disc as a point of focus, you can start from this area and move around, not causing extensive traction to remove the epiretinal, the ILM. And by this way, you make sure that there would not be any reproliferation on the fovea, especially, and this is the initial tear that was there and causing the rhegmatogenous element. And in this eye, I put silicone oil, and this is the post-op image. With the silicone oil, the best corrected visual acuity was 2100. Finally, this is the last patient. This is the myelinated nerve fibers, but he had extensive retinal fold, as we can see, and the fovea is highly corrugated. And this is, again, it's the same technique. I'm using 360 degree to remove all the posterior hyaloid and gaining access to the central area. And then with just the cutter, you can remove, pulling a little bit just to elevate it, and then you can gain access to this membrane. And here again, just with the cutter, we can gain access to this membrane that causing the fold in the retina along the arcade and extending to the fovea. Better magnification or high magnification is always better visualization, at least in my hand. So I will be able to see and differentiate exactly where I'm cutting and where I'm using the cutter. And this is again removal of the amalgam of the membrane and the posterior hyaloid. Again, ILM peel was, in my understanding, a crucial element of success in this patient. Again, trying, and we can see here that the posterior hyaloid is always thickened in these cases. So this is a diseased ILM. It is not a normal ILM, not like, for example, the macular hole or macular surgery. This is very thickened and toughened posterior ILM, sorry. So I think it is crucial to be removed, and I'm removing it as far as I can. And then shaving of the vitreous bevels, removal of any residual vitreous hemorrhage to prevent reproliferation again, and to allow for peripheral laser to be done properly. Sometimes I leave some element of kinocort at the end. And this is the post-op image. Immediately, the vision improved in this condition to 20/30 in the right eye. The left eye, I skipped it. So thank you very much. This is actually the part of the vitrectomy and this diabetic cases.
You're already, mashallah, exceeding the 20 minutes. Thank you. Anyway, we will have now a live question. Then we can have a discussion, and then we'll have Dr. Ahmed. Then we can go back to you, Doctor, after that. Okay. Can you provide us, please, with Dr. Hassan Nasser, live, Mr. John? If Hassan is available with us, can you unmute yourself, Mr. Hassan, or Mr. John, unmute him? Okay. We can hear you. If you want, please, you can go ahead. Hassan? Dr. Hassan. Hello? Hassan? Okay, meanwhile, till Hassan is ready, he can talk anytime. Okay, Dr. Ahmed, في سؤال, is there a macular hole in the first case, Dr. Ahmed Khashab?
No, there was no macular hole in the first case.
Okay,
no,
did you use
all of them? There was no macular hole.
Okay, did you use viscoelastic separation of membrane? And if you use it, are there tips for using?
I tried it, but I failed. So I'm not using visco dissection anymore, despite that Carlos Pateo was presenting. I think visco dissection was in an excellent way, but with a special cannula. The cannula is curved, so that it can go underneath the fibrous proliferation and can cause separation. But any direct injection will not allow the viscodissection to be working. In my hand, I'm not using viscodissection at all. Only in such a broad epiretinal membrane, I'm using bimanual technique.
This is a comment from dear Dr. Ahmed Al-Barqi. I think this one for either Dr. Singol or Dr. Shbadra. As the Rainbow trial, you can repeat the injection up to treatment in 28 days.
Yeah, so in Rainbow trial, they had almost 40% recurrence after ranibizumab. So it was a very high recurrence. I don't use ranibizumab. I use Avastin, that is bevacizumab. And the reported recurrence and what we see is only 5 to 10% patients will recur, even with monotherapy. So I don't do as much monotherapy. I do combined therapy. So my recurrence rate actually is very low. With the Avastin, the recurrence is only 10%. And especially if you make sure that the baby gains weight and is off oxygen and other things, then they do better. So I didn't really need to repeat the anti-VEGF in most of my cases, except as I said in some of the surgical cases. But maybe the types of patients are different or something else is happening, but I don't see that.
Okay, Dr. Ozdek, maybe Dr. Yasingo, you want to comment? Please go ahead.
I agree with Spadra. I don't do re-injections in ROP cases with the anti-VEGF, with any anti-VEGF. What I usually do is I do injections for the posterior disease, I mean zone 1 or posterior zone 2. And whenever it comes to the anterior zone 2, and if I feel that it is just recurred, I do laser, not the anti-VEGF again. Because if there is peripheral avascular retina remaining persistent, those I don't usually follow them beyond 6 months. Beyond 6 months, it's really difficult to follow those patients, those babies' peripheral retina, and it's really difficult examination. Then I don't want to leave them alone because they may not come because it's not causing any problem. So they may come with vitreous hemorrhages or tractional defect with the complications. So what I do is I don't let them to recur, and I just do the laser to the peripheral persistent avascular retina. And if I feel it is recurring, I do laser. That's it. So I agree with Subhadra.
Okay, we have actually many questions also coming from YouTube. There is a lot of attendees in YouTube, but I think we need to go to Dr. Ahmed, then we can keep all the questions to the end. It's better. Dr. Ahmed Salam, I know you are in the clinic, so, and we want you to do your presentation because you have maybe a short time without patients.
No, actually, I'm good with time now. I finished the clinic when I rejoined, and I'm re-enjoying the beautiful talks and the excellent moderation, of course.
Not like you. Not like
Thank you so much. Okay, I'll share my screen. Yes. I'm presenting as well on diabetic retinopathy. I'll try not to repeat the things that Ahmed said. I'll just say the points that are different. Can you see my screen now?
Yes, we are with you, yes.
All right, fantastic. I'll just start with a simple case here. It's a quiz. This is a patient who had a vitrectomy for diabetic proliferative disease. She also, the background of that, she has undifferentiated panuveitis as well as the proliferative disease. And that's actually a next day appearance. So she had this vitreous opacities, new vitreous opacities, and then the resident was saying she either had a rebleed or she has endophthalmitis very early. And you can see all these threads in the vitreous. If one of the if the audience on YouTube would like to try to guess what's that, but again, for the sake of time, I'll move on. That's a post-vitrectomy fibrin syndrome. We see that in diabetics, not very common, but we see it in lung cases. And that was not so extensive, but because of her background of uveitis, I gave her intravitreal TPA. And this is the appearance after 30 minutes from the intravitreal TPA. The 0.3, it works like magic. And intracameral TPA as well works like magic if you have fibrinous uveitis post-surgery, or patients was presenting with fibrinous uveitis. I used a lot as well. And in 20 minutes, it just disappears. So it's just something not very widely used, and I thought of just mention about it.
Same concentration, Ahmed, 40 microgram
yeah, so
or?
50 micrograms for the vitreous, 25 microgram for the antechamber. And if anyone interested in the preparation, I can send you a sheet that I prepared a while back, and we use this for the dilution. But it really works like magic.
I think it would be great to share it. Great.
I'll send it. I'll talk about diabetic retinopathy, and I'll be quick. I just want to touch on crucial point. This is not a patient with proliferative retinopathy. This is a patient with vitreomacular traction and ERM. But I just want to show you crucial points here. In this patient, so this is not a diabetic patient. Epiretinal membrane and vitreomacular traction, the hyaloid is attached. So we peel off the hyaloid. Here, after peeling off the hyaloid, you can see the epiretinal membrane, right? So then we remove the vitreous. Now the epiretinal membrane, which is a localized membrane on the macula, you can have edges and you try to peel off. And that's what I'm doing here. And because the retina is just, the fovea is very thin, I'm peeling all around, and I end up with like a flower petaling here. I'm just going to show you the picture. It's an interesting picture. And then I take off that with the cutter, right? So why I'm talking about this now, and this patient did well, because this is really what you don't see in diabetic. We don't have that in diabetic. And this is very crucial point. The vitreous is not separated from the epiretinal membrane. It's not like in non-diabetics. So 97%, if you have tractional retinal detachment or traction, 94 to 97% would have vitreoschisis, where the vitreous is complete with the membrane. And that was shown before with Dan Gregor many years back, and was shown also in OCTs more recent. And if you can see here, these two arrows there, that's actually the vitreoschisis. And if we, also another crucial point is the vitreoschisis tend to be less over the macula and the optic nerve. And this is a very crucial point, because you can see like sometimes people saying, okay, we go vitrectomy, we remove the vitreous in diabetic patient, we take off the hyaloid, then we go and remove the membranes. In my experience, this is not the case. The membranes in diabetes are actually part of the vitreous. And I'll show you something here. If you look into my arrow here, can you see my arrow moving?
Yes.
Okay, look here. Don't look at the membrane I'm reflecting, but look at here. This like glitter on the retina, because I'm actually not in the correct plane. I'm trying to go there, and that's why I couldn't get this membrane, because it's actually, this is not the correct plane. The correct plane is peripheral here. So to get actually to this membrane, you need to go back, scratch the retina, and lift off. And that's a very crucial point. And I'll show you this well as well. So here, this is a diabetic case. So I'm getting to this membrane. I'm just going to the side, and okay, and going with the cutter. And this is the crucial point here. Look, so, okay, we're getting here. But because now we got to this plane correct, we can actually remove the hyaloid. And you'll see now the hyaloid is there. The hyaloid is just part of the membrane, and the membrane is part of the hyaloid. It's so crucial, and that's why you have like several layers of membrane, because it's still not in the correct plane. So that's a point really I'd like always everyone to understand doing diabetic surgery. And my boss always explained this to me many times, is the vitreous is part of the membranes, and the membranes are part of the vitreous. This is different than non-diabetics. So for this reason, really, I always start dissection in out, which is not the usual. But because I get away from this issue of vitreoschisis, because once you're in the plane here over the nerve, then you're really in the correct plane and you don't have the issue of vitreoschisis. So I would peel off over the nerve or slightly over the macula to get into this plane, and then I move from in out, and then I'm really in the correct plane from the word go. The problem is you have more risk of bleeding because it's more vascular there. And I usually don't peel the ILM unless really it's a case where the macula, I'll spread that, where the macula itself is involved with the traction. Otherwise, I leave the ILM alone, and that's the same technique here, just lifting off with a forceps over the optic nerve and the macula. And you have to be very cautious when you pull over the macula. So I pull more over the optic nerve. You cannot really cut the optic nerve. And then I start the dissection in out, and that tends to work so well. I do bimanual dissection as well, but I think really when I'm in the correct plane, things become much easier. I want to show this. Someone asked about visco dissection. Okay, same technique. Pull off a little bit, get the plane correct, right? And then after that, I use a visco dissector, a Hubbard visco dissector, which is a curved. I'll speed to this here. Yeah, that's the Hubbard visco dissector. So you go and lift up, and it has a nice curve, and then you inject. And I think it does help a little bit. I don't use it so often, but it's nice. It's a nice tool to know, lift off. But the one thing don't do is some people inject like dye. I wouldn't do that because sometimes you go under the retina if you inject too much. You don't want dye to go under the retina. So let me show you my case here. This is a combined traction rhegmatogenous detachment. I've done this see-through title myself, so I'm very proud of it. It took me like 1 day to do it. So okay, so this is a Nigerian patient who came saying, we know CC. We know CC, like this is a broken English. We say, I don't see, right? But they would say, I know go, which means I don't go, or I know CC, which I don't see, right? So here, this is the case starting here. And you can see this is the cause of the combined traction rhegmatogenous detachment. I'm sorry, I skipped that quickly. This is the case here. And you can see this is not only traction, there's a tear somewhere because the retina is very bullous. So the cataract surgery, I leave the viscoelastic initially, and this is the tear here. And then I reuse the cutter a lot. And I think the cutter, you can do most of the things with the cutter. And I do like what Shengul was saying for ROP. I try to be conservative and I try to cut the traction, but I don't try to remove everything. If I can, fine. If I cannot, I don't want to create breaks as much as I can. Because in my view, these eyes do much better if you remove the traction over the macula and the optic nerve and the breaks. Otherwise, really, then you end up with tears. And if you have tears and undissected membranes, then you use oil. And in my point of view, if you use oil in diabetics, for me, this is the end of the game. And I really don't remove the oil because these eyes do very bad. You get all this retro oil membranes. So I just conservative segmentation. And here, this is nice. This is, if you look here on the side, the numbers here on the cut rate will go to 20,000 because that's a 27 gauge cutter. And I'm using that more and more now. It's really nice. You can get very nice under the membrane, between the retina and the membrane. I don't think the cutting is the thing that is a high cut. I think it's the size. It's a very small instrument and the bevel is very near to the tip. And I really like it. I think it's a very nice instrument. And I'm using more and more of that even from the beginning of the surgery. I don't use it in anything except in diabetics. And here, and then here I went with bimanual delamination. And I think, as Ahmed was saying, there's too much traction going on and that can cause tears. I think the retina is also lifting up because the membranes are removing and I ended up causing a tear here. So I just told you don't cause tears, but if you create a tear, don't stop. You have to clean around it. So that's what I'm doing here. I'm cleaning around it. And then I went here with more bimanual delamination, which really, I fancy more the cutter delamination. Bimanual is good, but I think you can do most of the things with the cutter. And then here more. And again, so we have one break and I created one. And then bimanual. And then I thought that's good. I mean, we cleaned everything as much as we can. There are segmented membranes, just leave alone. The retina looks fine. And I put PFCL. And then this here was the issue. And it took me a while to decide what to do because there was too much fluid. I did a retinotomy and I drained from it. Thinking back again, I should have tried something different other than creating another break in the retina in diabetics. I chose a clean area to do that. But maybe I could have drained from outside or push the fluid and then laser if I need to laser and then push it the other side and leave the fluid. But anyway, I created in a good site. And then I'm planning now to put air. So this is a very important point for new surgeons. When you manipulate the eye, anterior segment, always switch off the posterior segment infusion, clip it, and make sure you do this before you put air. Otherwise, everything is going to be up in your face. So I switched off the infusion, removing the viscoelastic, and then go for air, and then gas. And this patient did so well. And you can see here, I don't remove everything. I segmented the membrane. I cleaned around the tear, which is the most important. And I think what Shengul said for ROP, I think applies so well for diabetic retinopathy. Less is more, and you don't need to really remove everything. So I just leave you. Are we good with time, Dr. Mohammed? I don't want to be taking too much time.
Okay, you have more?
I just have a summary here. I just want to show you two things. This is from the UK, looking at national data. So the tamponade used, silicone oil is used in 15%. We couldn't tell really which eye used oil from this data. Then the other one really is retinal tears, about 27%, which really what I found in my hand. Retinal detachment, a rhegmatogenous detachment, is actually low. So if you treat that, and I think if you be conservative, you do more. And most patients would improve. Repeat vitrectomy is high, we know that, for vitreous hemorrhages or residual traction, and good line of visual gain. So that's what I tend to do. If I can remove all the membranes and create no tears, fine, I'm a fantastic surgeon. Usually this is little. If I think that actually these membranes are going to tear, or I try them and it's tear, I would just leave some membranes and end up with no tears and air tamponade, and that's really a second good. No membranes, few tears, and you cleaned around them, fine. Put gas tamponade, fine as well. I think the above one is even better. But membranes and unrelieved tears, that's really, in my view, is unsatisfactory. You end up with oil, and I tend to leave the oil for life. So I tend to try to deal with this eye as ROP cases as much as I can, and less is more. Thank you so much.
Thank you very much. As usual, Ahmed, very going to the point, very specialized in videos. So you are learning now how to edit very nicely. So we'll see next time a new style of editing.
I hope so.
We have questions, but also actually I want to go back to Dr. Ahmed Al-Khashab. Ahmed, you are there?
Yes.
Dr. Ahmed, so you can, if you go fast and do the last talks, please, so we can have at the end the questions. Yes, please go and share. Can you stop?
Can you stop Ahmed sharing?
Yes, yes.
Okay. Okay, we are having a questions.
Can you see my screen?
Not yet, Ahmed. So we start sharing till we get this answer of this question. What are the role of anti-VEGF in CSR? Ahmed, Dr. Ahmed Salam, Dr. Shubadra, Dr. Singol, if you want to participate.
Only if there's CNV. I only use it if there's a choroidal neovascular membrane on the CSR, which is not common.
Okay, Singol, you are saying?
Sorry.
What are the role of anti-VEGF in central serous choroidal retinopathy?
Yeah.
CFR.
Actually, these are for the, we can call them as pachychoroid diseases. And if you have a pachychoroid neovasculopathy or neovascularization, we can think about that, I mean, the anti-VEGF. But even in those associated with, you know, pachychoroid neovascularization, PDT works quite well. So I would first try PDT, and if it doesn't respond, then I can think about anti-VEGF.
Ahmad, can you share
Depends
your...
on the case.
Ahmad,
Yeah.
we are waiting you to share, please. Share till we answer the question, because you didn't share until
Okay.
now.
I was waiting for you.
No, just
Okay.
share. We can continue while you are sharing. Okay. We are having also a questions. Okay. You are
Okay.
ready? Okay, you can go ahead.
So I'm just talking very quickly about a few cases of diabetic macular edema and chronic DME. So this is a 61 years old male patient, hypertensive, diabetic, not greatly controlled diabetes. His visual acuity is 20/70 in the right eye and 20/25 in the left eye. And he had, when he presented to me, 4 anti-VEGF injections and some nuclear sclerosis, moderate NPDR, not extensive, as you can see in the photos here in the right eye and in the left eye. This is the edema in the right eye, 439 micron central retinal thickness. And for this was given another type of anti-VEGF with initial improvement. But again, with monthly injection, it did not improve that much, and the edema remained the same. So I explained to the patient that we need to opt to another modality of treatment, which is steroid injection. And I started giving injection of Ozurdex for the right eye in 2016. And actually he improved. So he was initially responsive to anti-VEGF, and that not very much. And then he improved with the Ozurdex, as we can see in the photos here in the right eye. I did not give anything for the left eye. 5 months, he recurred back again. And that's what we know from the MEAD study, from all the studies. It will not remain for 6 months. So 5 months, he recurred back again, and then improved tremendously. And the vision improved to 20/25. Then again, 4 months now, he started to reaccumulate the edema once again, and he was injected. So this was repeated, and the patient was complaining about the repetition of the injection. Here, actually, he started to develop nuclear sclerosis +2 in the right eye. So that's why the visualization was not that clear. So I opt to do a combined procedure of phaco plus IL and Ozurdex in the right eye. And this is the image post injection. But once again, he restarted again the edema, and now it is 3.5 months. This is after the Ozurdex again injection, and once again he started to have. So we did not have any proper treatment so that to decrease the burden of injection for these patients until we have the Iluvien.
Can we mute, please, all?
While you're streaming, you're going to probably want to be able to hear your own microphone.
Hello?
And you're going to want
Can you mute all the speakers, also all others? They are hearing under sound.
a multi-output device that contains those two things
Yeah.
for you to listen to.
I think it's Marvision team. If please, Marvision team can mute.
Marvision, can you please mute all? Okay, Ahmed, now please. Sorry.
I think they muted Dr. Khashab as well.
No, Khashab, you can talk. We can hear you.
Yeah, now I can talk. So I injected him Iluvien, and this is post-injection. And my experience in this patient, actually, he improved initially. You can see the central retinal thickness. It was 300 micron 1 month post-injection. And then he started a little bit of reaccumulation of some fluid, 315. I thought maybe he will need in the future top up. But once again, with the follow-up, he did not need anything, and the central retinal thickness goes back down again to 277. So we should give it a bit of time for the Iluvien. And this is now 6 months. He did not need any further treatment. The IOP did not go up, and I did not have any problem, especially of the cataract, as you explained in your beautiful presentation, Mohammed. The rates of cataract is 80%. So he did already, is a pseudophakic patient. This is another patient, a young patient, 31 years old, controlled, but he did receive a lot of injections before he presented to me, 16 anti-VEGF injection and a lot of PRP and grid laser. And the lens was clear, and he had a stable diabetic retinopathy, despite that there was a fibrous proliferation from the disc, as you can see here in the right eye. Extensive laser, not just peripheral, and some grid laser that was done elsewhere. And the edema, you can see horrible in the right eye. So 1,200 micron at presentation. So again, I tried another type of anti-VEGF. He initially responded, but the vision, the edema recurred very quickly. So we opt to use Ozurdex for the long, so to stay for longer duration. And again, repeated recurrence whenever the effect of the Ozurdex fades away, until recently I injected him. This is the 4th injection of anti-VEGF. Sometimes he needed anti-VEGF in the left eye, and usually he needs only 3 to 4 injections per year for the left eye. So once again he recurred back again in the right eye. So I opt to give Iluvien. I gave him in December last year, Iluvien, and this is maybe 2 weeks after the injection. We can see that tremendous reduction of the edema, and then the edema is totally subsides. The vision improved to 2200, but the cataract started to increase even more. Despite that he developed already some element of nuclear sclerosis and posterior subcapsular cataract with the repeated Ozurdex injection. But the edema is totally gone, and now almost more than 6 months. I wanted to touch up about the, this is a newer study, which is the user study. The user study provides valuable real-world clinical insight on the visual acuity, edema, and safety before and after Iluvien implantation. At the time of the pivotal Iluvien FAME study, there were no approved treatment for DME. Therefore, outcomes in patients after prior injectable therapies could not be assessed. In user treatment used before and or after Iluvien included a laser, intravitreal anti-VEGF, and steroids. So the treatment before or prior to Iluvien was anti-VEGF in 77%, 56% steroid, and 50% laser. The persistent DME post-Iluvien was only in 37% of cases. 63% of cases did not need any further treatment during the follow-up. The follow-up is not 3 years. It's about 1.5 years to 2 years in certain cases. And whenever the treatment, so regardless of the visual acuity at the time of Iluvien, persistent DME patients required fewer treatment on average after receiving Iluvien. So whenever needed, there is in the 36% in patients with lower visual acuity, they needed the retreatment at a shorter interval, about 6.7 to 7 months. While in a better visual acuity, they needed treatment only after 15 months to 22 months, which is almost 2 years. User data confirms the benefits of continuous microdosing delivery on retinal edema. As we can see here, the eyes with equal or less than 300 microns are more after the Iluvien injection, reaching up to 80%. User in the study, patients had persistent DME and benefited from treatment with Iluvien. Persistent DME is DME that persists or recurs despite treatment. many patients were responding initially. Like the two patients that I presented, they were responding to Ozurdex, they were responding sometimes to anti-VEGF, but they would not be able to persist on monthly injection with anti-VEGF or 3 monthly injection with Ozurdex. So the indication for Iluvien in my hands nowadays is not just patients who are resistant to other medication or not responding to anti-VEGF. Sometimes patients are responsive to other treatment, but they will definitely go into better treatment with longer acting drug like Iluvien. And thanks a lot. Thank you very much.
Thank you very much, Ahmed. This is very interesting also. So if I will ask you, Ahmed, also about the Iluvien, do you think we should use only Iluvien if there is, as you mentioned, only if there is no response, or sometimes if we can give even if those they are respond, but they are having a high recurrence or number of recurrences more, as I mentioned in the real ideal study. Also, the other question is came that whenever we delay the treatment, do you think it will not affect about the beneficial of the treatment? Even if you have a dry macula, but you delay a lot of treatment, what is the result it will be regarding the improvement in the visual acuity, if they will have an ischemic changes and so on?
Excellent question, Mohammed. As this study showed, and in these my two cases, and I have 3 or 4 more cases similar to this two. I think sometimes when the patient even responsive to anti-VEGF or Ozurdex, but they needed very frequent injections, either monthly or in the Ozurdex less than 3 months. I think we should opt for a longer acting drug, microdosing like the fluorouracil implant, the Iluvien, I think would be very beneficial. If the macula is dry, I don't think that we should treat at all. Whenever we reach that the macula is dry and we finish the loading or whatever the regimen that we are using, and then we opt for the, for example, for the anti-VEGF, the treat and the extend the protocol, the aim is to maintain the retina dry. But we should not be treating or overburdening our patients with extensive and we can extend the treatment interval between these dry retina, this with dry retina.
Dr. Singol, do you have any experience with using Iluvien in treatment of chronic diabetic macular edema? Please first, you are unmute. You are, okay.
Okay, I did. Mohammed, we don't have Iluvien in Turkey, so I don't have any experience on that. But we have cases with chronic diabetic macular edema and which needs continuously injections, especially as like those shown by Dr. Ahmed Kasab, those with cystoid macular degeneration, large cystic spaces in macula without Muller cell septas. In those cases, you need it. So I think it may be a good solution for such cases, especially it's already a pseudophakic case, especially, and if no glaucoma, then I think it will be a good solution for such cases.
Thank you, Dr. Singol. Dr. Ahmed Salam, I think you are having a good experience with using. So you can give any comment about using Iluvien.
Yeah, sure. Yeah, I use Iluvien for diabetes and diabetic macular edema. And same scenario, I usually start with anti-VEGF. I may switch anti-VEGF once for injections. If I'm not getting response, then I will go steroids, either Ozurdex. Usually I would go Ozurdex first, and then if we're requiring more Ozurdex, I would go Iluvien. In some patients, I went Iluvien from the beginning when I moved from anti-VEGF. In uveitis, it's a good drug. So it's here in the US under UTIC, just a different company and a different injector, but it works very well in uveitis. Still, in very bad cases, I still suture Retisert. Retisert is 3 times the dose of the Iluvien. So it's about 0.6. Sorry, it's about 0.6 milligram, where the Iluvien is 0.2.
Dr. Shubhadra, you have any experience while using this one, Iluvien?
So I was one of the PIs for the original frame study, and
Okay.
we
This is a
used it
good
at
chance
that
for us
time.
to be with us.
And even before that, the uveitis study with the fluorescein implant. So yeah, so but I don't use it that much now. It's a little expensive here. For some of our uveitis cases, we definitely use. Um, uh, but yeah, if there is a patient, we can definitely use. There is no issue with that. I have not recently, because now I don't deal with that much of diabetics. I'm doing only pediatric retina. So I can check with some colleagues whether they are using. I didn't see them. I saw some of my uveitis colleagues using, but I didn't see the diabetic colleagues using it much. But yeah, but it's very effective. It's very effective.
Thank you. We will have now some raised hand. Okay, if you can start with Dr. Saad Wahib, if he's there, please. Saad or Dr. Omar, whoever is there. Dr. Ahmed Al-Barqi also. Uh, okay, so we have Dr.
Hello?
Saad or Dr. Omar. Dr. Omar, you can go ahead, please.
Hello?
Yeah, Dr. Omar, we are hearing you, please.
Not Omar. I'm Al-Barqi.
Ahmed, okay, because Omar is there, Ahmed is there. Okay,
No
Ahmed.
problem.
So we are.
Thank you, Dr. Muhammad, for the nice presentation, nice gathering, and excellent presentation from the all speakers. Very eminent speaker. Very thank you for much. Just 2 points. I want to be so quick for the ROP and the Lucentis. We have some experience with injecting Lucentis in ROP babies. My point that as Rainbow trial, you said that we can retreat this twice only. It's not treatment like anti-VEGF or DME. Just you have 2 injection maximum, and then if this progression or plus disease is coming, you have to do laser. In my experience, the value, what I feel the advantage of using injection at the beginning, if you give 1 injection and after 28 or 27 days you give another injection, and still you do laser, at the end you find that the area of laser or near DB laser will be smaller than if you start doing laser at zone 1 or zone 2. So the idea is to postpone the laser a little bit so that save the retina to avoid the myopia later on. That's my point regarding the Lucentis in ROP, because we don't use Avastin. One point regarding the Dr. Khashab and Dr. Salam from US, it's very excellent talks about the tips and tricks in diabetic. But I just wanted to comment that, in diabetic, the vitreoretinal attachments, it's have something grading system or scoring. There was a nice paper talking about that. I found very useful because you have from type 0 or grade 0 until 5. So starting from focal vitreoretinal attachment or vitreous attachment, focal to broad, then attachment to the macula and disc, and then total attachment. So the trick, if you wanted to peel this or remove or separate the vitreous in diabetic patient, as Dr. Salam showed that it's vitreous chisis is very common. So I believe if you start peripherally, not centrally, you will make sure that all this area is only vitreous or vitreous chisis, not membrane. So you go back, what we called out in. If you start in out, some cases, yes, I agree, but you have to worry about the risk of inducing tear in the posterior pool or the posterior retina, because if you have some small attachment or from type 1 to type 2 attachment, yes, you can start in out, but I think it's more safe to start out in to avoid or making traction or making tear in the posterior pool. And also you'll find a plane for your dissection more easily, because peripherally there is most commonly only vitreous or vitreous chisis. There is no membrane in the periphery, but then you can find your plan and you start peeling from out in a safe manner. That's what I wanted to highlight. Thank you for your
Ahmed.
presentation.
Okay,
Very nice.
we'll have
Thank
first the comment, Dr. Shubhadra. about his, I think you comment about that before, but if you
Yeah,
want
yeah.
to very, yes, Dr.
So,
Shubhadra, yes.
yeah, so so as I said, the main thing is that when I give anti-VEGF, it's mainly because I cannot do laser, and I want the posterior pole to mature and not do too much laser. The reason why we are then doing the combined treatment is so that the patient's follow-up can be reduced. That's the main thing, because our patients come from 500 miles, 700 miles, and they cannot stay in the city, and they cannot go and come back. If they are from the city, then it is different. But we don't get AP-ROP from our city, because our city has very good tertiary care. We get all
Okay.
the AP-ROP from the rural areas, and they have a problem of follow-up, and there's nobody out there who can examine them after we inject. So usually we do combined treatments for them.
I mean, he was concentrating about repeating the injection, uh, not only once. This is the main things I think Dr. Ahmad was talking about.
Yeah, so he was saying that we can repeat the
Yeah,
anti-VEGF. So that's
yeah.
what I was saying, that one, with Avastin we don't get that much of recurrence. Second, we are not doing monotherapy in most of our cases unless they are from the city, and we don't get much of AP-ROP from the
Okay.
city. So the patient profile is different, and so that's why the way we treat would be little different. And
Dr.
as far
Ahmad,
as the high myopia is concerned, yes, the more posterior we do laser, the more high myopia we get. But even in the BEAT-ROP study, where they did monotherapy, about 15% of patients had more than -8 myopia. So never promise your patient of anti-VEGF that they are not going to get myopia. They can still get myopia.
okay, excellent. Can we have Dr. Ahmad Salam comment about Dr. Ahmad Al-Barqi?
Yes, yes.
He's
Thank you so
bleeding
much.
in, out, in, you are bleeding in, out.
Yeah,
So,
no, I think I think whatever works in your hand, but the problem is if you go out in is you have this vitreoskisis, and in many occasions I feel that like you think this is the correct plane. It's very difficult to detach the vitreous peripherally. So I think really what works for me very well and has always worked well is to go in out. And I don't really, I'm not aggressive shaving vitreous base. I just do the minimum required. So that's my belief. I believe in out is much easier really and much safer. The only issue is you can get more bleeding, but with anti-VEGF before, I think that works well.
I think it's a different, I mean,
Yeah,
experience.
it's
And
like
if
people
it is good
chop
with
and
Ahmad to go from in, out, and you are out, in, it's all same. We will have Dr. Omar Ali, if he's there, if you can, Dr. Omar. If not, Dr. Omar, if you are with us, Dr. Omar, or otherwise we can have Dr. Gita Sheen or Git Haseen Rajab. Can you open? Or and then we are having, yes, Hatem Dweda. If there is Dr. Hatem, you can open. Who is ever there, you can open for him the mic. Meanwhile, you are. I have these questions also. Why
Yeah,
using
actually,
silicone? Yes, who is there?
yeah, actually, Dr. Ahmed Al Bakri has went to the point that I want to ask Dr. Salam about the in-out technique with the risk, is the high risk of getting retinal tears at this crucial area.
Okay,
I don't think
so
there's a
we,
risk of retinal tears. I think it's mainly bleeding. On the contrary, really, the adhesions around the macula is loose. You don't get breaks in the fovea. You
I
get
mean
break.
by how to be sure that you are in the correct plane
You're
and
100%
you
in
are
the correct
not
plane.
under the retina. I mean,
No,
yeah.
you're 100% on the correct plane. If you peel over the disc, you're 100% in the correct plane. If you look at the OCT I showed with the vitreoskisis, the way it works, it's minimal on the macula and on the optic nerve. So it's 100% you're on the plane. There's no like way you lose the plane. I think it's the issue really is the bleeding, but there are no tears because this area, the attachment is loose to the macula and you cannot really tear the optic nerve.
And this usually is a condition, right?
Yeah, it's 94% of the cases of tractional detachment would have a vitreoskisis.
Okay.
You can work
Thank you.
out in. I mean, it's just really the way that I tried and I was shown by someone and I thought it worked so well.
Yeah, thank you.
Thank you so much.
Thank you, Dr. Hatem. We can have one question, Dr. Ahmed Khashab. What is the
Doctor, can you hear me?
Yes, who is with us now?
Yes, thank you all for this amazing presentation. My question is to Dr. Salam. Yes, I am Dr. Omar.
Yes, Dr. Omar, go ahead, please. Yes.
Yes, my questions to Dr. Salam.
Yes.
When will you stop there and say there is no indication for vitrectomy for this patient with diabetic retinopathy? This is my first question. My second question, is there any rule for anti-VEGF to be given days before vitrectomy to decrease intraoperative bleeding? Thank you very much.
Thank you, Dr. Omar. Yeah, Dr. Ahmed, the question.
So I think that the first question was when not to operate, right? Is that correct?
Yeah, when to stop.
Yes, correct.
When not, I think really if the vision is very poor and the retina is very ischemic, then I think you're not going to achieve anything. And you get a feel really whether this is traction or the retina, the eye had it and the disc is pale. And I think in these cases, it's better not to intervene, especially if the other eye is good. So, you know, in these cases, we all have a feel for them. So I try not to operate on these cases unless really the patient is very desperate and no vision in the other eye, and you feel actually there's a good traction there that maybe he would benefit. But that's a great question. The second question is, yes, I always do anti-VEGF. I do it about 2 to 3 days before. If you look, there was a beautiful paper from my late friend, Dr. Hazem al-Sabbar, and they showed beautifully that the angiofibrotic switch is maximum at about 7 to 10 days. So I tend to operate before that. I tend to operate on 2 or 3 days before. And I think it works fantastic for intraoperative bleeding and for early post-op bleeding.
Thank you, Dr. Omar. Thank you, Dr. Ahmed. We'll have a question for Dr. Ahmed Khashab. What is the best to be done, Dr. Ahmed, for post-phaco macular edema?
Thank you, Mohammed. For combined cases, we can go for both, whether anti-VEGF or Ozurdex implant at the same time or prior to the phaco. So either inject prior to doing the cataract surgery or doing it meanwhile you are doing the cataract surgery, and both work fine. Steroid can cover both the all anti-inflammatory mediators, but anti-VEGF as well can work beautifully in these cases. So I'm using both. Actually, I agree with Ahmed Salam about his indications. I usually prefer to gas than silicone oil in cases of diabetic retinopathy. Actually, I prefer gas in all cases. But silicone oil is not an end game for me. Sometimes if I will need to put silicone oil in diabetics, I can remove the silicone oil in 3 months, 4 months, and they work fine. Actually, there is no statement of just putting silicone oil is an end game, except if it is extensive tears and you cannot really do effective laser to cover all these areas of tears or detachment, and there is persistent traction. And once you have this, I think you lost the game, but you should not be. And despite this, you can re-enter again and remove the silicone oil and tackle all epiretinal membrane if there was there, because actually I'm receiving some cases secondary to other surgeons from everywhere, and I remove the silicone oil, remove any residual epiretinal membrane, and deal with it as a fresh case and tackle it in a, I think that's, yeah, I disagree with this point.
Okay, Ahmed, thank you. Can we be just a very direct or very short question, because we are running behind the time. There is one question from Ziad Hussein. What is the risk of using silicone if you did a good vitrectomy and remove of membrane? If we can have Ahmed or Singol also to answer this question. I know you didn't do the presentation, but you are a vitrectomy.
Okay. Actually, I was trying to type the answer for that question. Thank you for giving me the chance. Actually, I really like to use silicone oil for bad diabetic eyes. What I feel is it's when you can remove all the membranes, if it is possible to remove the membranes, you feel it silicone oil quietens the eye actually, and it gives you a second chance during removal, if there is any residual membrane or anything like that. And the patients usually feel better when they start to see earlier after the surgery because there's no gas. And since the retina is ischemic in these eyes, in very bad diabetic eyes, you can have some atrophic retina, and you can have some small, very like bird eyes-like holes in the atrophic retina. And when you use the silicone oil and do laser and silicone, remove the membranes, do laser and give silicone oil, it covers all those pathologic areas and prevents many complications. So I like to use silicone oil actually in those eyes, especially if there is a combined tractional and rheumatologic retinal detachment. I always prefer to use silicone oil. Probably it's different, we think differently, but in those bad eyes, if you can remove the membranes, it will be better to use silicone oil for me in my hands.
Thank you very much.
Also anti-angiogenic. It has very good anti-angiogenic properties. So, if I'm not doing diabetic retinopathy now, but I've done for 25 years. So silicone oil definitely works when, especially when we didn't have anti-VEGF, or even after that, it prevents neovascular glaucoma in some of these eyes, especially when you're doing combined cataract and retina surgery. Sometimes the retina is very boggy. You don't get very good laser. Then they will develop NVI post-op. But if you put oil, it just, has an anti-angiogenic effect. So the whole thing quietens down, and then you can do the laser and all. So in addition to acting as a tamponer, it also prevents neovascularization of the iris.
Thank you. You have any comment, Ahmed Salam, because you are the one who presents.
Yes, I actually have a comment. I mean, I think what was not mentioned is the retro oil membranes, and that's why really in Europe and US, especially in West Europe, they shy away from silicone oil in diabetics. You get this retro oil membranes, which defeats the purpose of the dissection. The other thing about I know, I just in reply to Ahmed Khashab, what we're saying, in my hand, I only use the oil in this indication where there are tears, there are membranes on the tears, and I cannot relieve them. Really, there's nothing else to do except put oil, and that's oil for life. I'm not going to come back because I failed to remove these membranes. But otherwise, my threshold for using laser is oil is very low. And yeah, that's it.
Okay, thank you, Ahmed. We
so
have maybe the last questions. How much power of the other parameters used for micropulse laser? I think this one is related to ROP.
It's related to CSR or diabetic macular edema.
Yeah, or macular edema.
I don't use micropulse, sorry.
Anyone is having any? Ahmed
I tried it, but I'm in my understanding, micropulse does not differ much from the regular thermal laser. So, in my hand nowadays, thermal laser or micropulse laser has no role for central involving macular edema. Sometimes if focal outside of the macula, not centrally involving, some definite first-unit maculopathy that I can't have a touch of focal laser, I will do it, but it became very seldom. And no role of grid laser anymore, just focal if non-central involving macular edema. And this would be the same for micropulse.
Dr. Amri, just a quick reply. So I don't use it, but there are very good paper from Shoba Siravapad from Morphos on micropulse laser. And actually, you can treat the fovea with micropulse laser in diabetic macular edema. has roles as well in CSR, but I use PDT as well, like Sengul. So if anyone wants to look up these papers, it's Shoba Siravapad.
Maybe you can share, Ahmad, with me, send to me.
I'll try to get the paper. Yes.
Yes.
I will share that with you.
Okay. We have many questions, but I think Dr. Singol and Dr. Shubhadra, they answered them by written to them, right? So I don't need to repeat this one because they are about. Could please also share your pros and cons, Dr. Singol?
Yes, I have already shared my.
Okay. So all these questions already are answered. So I don't want to go again for these questions. So by this, we are already finished all. If there is any comment or any word before we end these sessions, thank you for all our speakers. Thank you for all our attendees. Thank you for Alimera for sponsoring this meeting. Thanks for also the management event for their support. And if there is any word before we move, Dr. Singol, because from your left side, I will go like this.
Thank you.
Okay. Thank you very much, and good night, and we'll see you, inshallah, very soon in another webinar. Thanks a lot. Appreciate your time and sharing your experience with us. It was a very interesting and good. And good night for all.
Thank you, Dr. Amri. Excellent moderation.
Thanks a lot.
Thanks, thanks, appreciate it.
Thanks a lot, Mohammed. Thanks a lot for Almira, and thanks all for the eminent speakers, Ahmed Salem, my dear friend, Sengul, and Dr. Shubhadra. Thank you very much.
Thank you.
So it
Yeah.
ends. So thank you again.
Thank you very much, Dr. Singol. I will wait for your reply about the question I give you in the early beginning. Nobody hear me when I ask you.
Which one?
About 12, I think. 12th of June.
Okay, I will just check it. Thank you. Thank you.
Thank you and good night.
Have a good night. Bye.
Bye-bye.
Again,
Bye-bye.
it was really good moderation. Thank you.
You are most welcome. Appreciate. My pleasure. Thank you.